All right. Hi, everyone. Welcome to this November's webinar session, Transplant QAPI Demystified, Strategies for Enhancing Pharmacist Involvement in Transplant QAPI. My name is Melissa. I am going to be one of the moderators for this webinar session along with Nicole. And can we get the next slide? And our presenters today will be Dr. Elizabeth Cohen from Yale New Haven Hospital, Manager of Transplant Quality and Compliance and Outreach and Clinical Pharmacist Solid Organ Transplant. Dr. Tiffany Kaiser will also be presenting, Director of Transplant Quality Program and Transplant Clinical Pharmacist from the University of Cincinnati, and Dr. Dimitra Sapepas from New York Presbyterian Hospital, Director of Quality and Patient Safety Transplantation and Assistant Professor of Clinical Surgical Sciences Transplantation at Columbia University Irving Medical Centers.
Thank you, Melissa, for the introduction, and welcome everybody to our webinar today, where we have three main goals that we're hoping to deliver our talk about. The first is to describe and define transplant QAPI, discuss the pharmacist's role in QAPI, and share strategies for pharmacist involvement in this realm. Next slide, please. So to start off, we are wanting to do a little bit of didactic and some basic level setting around what is QAPI. So QAPI stands for Quality Assurance Performance Improvement. And this is essentially a required element for a data-driven process that is mandatory for all transplant centers in the United States. It is comprised of a number of various sub-elements, starting, of course, with the number one most important thing is ensuring patient safety and quality, which follows. So components of QAPI include reviewing of adverse events that may happen, both big and small, and finding areas of opportunity to conduct performance improvement initiatives where they are relevant, trying to think about ways that the system can be improved to ensure patient safety and quality, taking into account for human factors where we can make changes that actually are also not people dependent, and we ensure safe care for our patients as they are going through the transplant journey. We also want to develop systems to improve these processes as part of quality assurance and performance improvement, and of course, iterate on these processes. So it requires a lot of tracking, and at the core is also data. Summarized here is a little bit more details around transplant data that we need as part of quality assurance and performance improvement, which is detailed, complicated, longitudinal. So we submit and collect data on patients for the entirety of their lives, starting from soon to be referral all the way to throughout their lifespan. This information is mission critical in the sense that it is imperative to look back and see what safe mechanisms we might put in place locally at an organization, but also for policy and for things like organ allocation, waitlist management practices, and of course, post-transplant outcomes. And basically what happens is we, as transplant programs, collect information about our patients, including demographics, social parameters, medical parameters and medical items, complications, and conditions. And this is outlining a little bit about the transplant data registry. It gets submitted to one of our governing bodies, the United Network for Organ Sharing, gets packaged very nicely every 6 months and submitted to the SRTR or the Scientific Registry for Transplant Recipients, which kind of does some number crunching and also provides each transplant program a report card. And these report cards are publicly shared and have really broad implications in the sense that they're reviewed on the SRTR website by entities like CMS, the public. So patients use this information to decide what transplant center they might go to, where do they know how to treat patients that look like me, as an example, and then also for payers and for reimbursement models. And there's a lot of implications to this, and it's really important that we have really sound systems, and pharmacists have a tremendous opportunity to be involved in these spaces in a variety of facets, and we're going to go through some of those as we spend some time together here. So I'll turn it over to Tiffany for the next slide.
Hi, everyone. Good afternoon. When we think about the pharmacist role in transplant QAPI, we can talk about what pharmacists do. We can also talk about what pharmacists could do. And the roles obviously are highly variable and really can be categorized in a number of ways. What we attempted to do on this slide was just give you kind of 5 big areas or 5 categories of the roles of a pharmacist related to transplant QAPI. So a bystander, a learner, a participant, a project leader, or a program director. And I'm just going to briefly step through these with an example. So let's say a QAPI project or something that's your kidney transplant team is working on is to reduce the number or the rate of 30-day hospital readmissions. So you as a pharmacist, your role in this project can vary, right? So you could be a bystander. So you could be passive. You may have an idea that the project's going on. You may have no idea, right? You're passive, no idea, no interest, don't know anything. Or you could be a learner. You know the project's happening. You want to learn about it. You're eager, you're engaged, you're curious. Or you could be a learner that wants nothing to do with it. You're upset. It's mandated that you have to learn about it. Participating, we all know about participating in a project, and this project or your level of participation could vary, right? You could be maybe just adding something in your pharmacist documentation if the readmission's related to something to do with their immunosuppressant. Maybe you add that and then the team takes that and includes that in this project. You could be involved in terms of meeting with this work group working on the project and have weekly meetings and participate that way. Maybe you're just doing data collection. So your participant level can vary. Makes sense then if you're the leader of the project, right? Here you're defining what are the goals and the objective of the project, what metrics are we going to use, how do we define success in reducing readmissions, what would that look like? And then lastly, as a director, and by a director, you're really involved with QAPI oversight. You could be a specific organ, so you're the kidney program director. You could be the director of all of Transplant QAPI. So you're working on really defining the program. What does it look like? Working with leadership, making sure you are adhering to the regulations and doing that. So your level of participation can vary. What we wanted to do today before we get started and really kind of discuss some of the opportunities or strategies is really ask all of you listening today, how would you classify your highest level of participation in transplant QAPI? So bystander, we went through present, not taking part, a learner present as an observer, participant, participating and taking part, the leader, you're on a project, or the director, really providing oversight. And we're going to have a poll here. If you could please take a moment and answer this. There really isn't, can you see that or is it on the wrong screen? There you go. This isn't a right or wrong answer. We're just asking you to please answer so we can help tailor some of the strategies in our discussions based on your level of participation in the audience of those of you on the webinar listening today. So we'll just give you a few, another 20 seconds or so to just select one of your highest level of participation. Okay, if we want to go ahead and close the poll. Okay, I know that we can probably have these, but I'm just going to write the percentages. So it looks like the majority are participants. Really about 3/4 of you are participants or learners. 11% leaders, 4% are directors, and 11% bystanders. So we have a really good mix. So we're going to try to, like I said, really when we talk about strategies and give examples, kind of put a mix in there to help some of you. If you're a learner and want to become a participant, or if you're a participant and want to become more of a program leader or something of that nature, how to kind of go towards that. Next, I'm going to turn over to Liz, who's going to share really her path and her perspective of going from a pharmacist into QAPI leadership.
Yeah, thank you everybody for having me today. So to talk about how I went from a pharmacist, a transplant pharmacist, into QAPI leadership. To talk a little bit about that, I wanted to go through each of those examples that Tiffany just laid out. So really first, as a learner, I was fortunate to train with an RPD who was really involved within transplant QAPI already. And so that was really helpful because I could actually see that my RPD's involvement, and see what the potential was for the pharmacist to be involved in QAPI. And so a lot of the things that I saw with my RPD was things like protocol development, or even sometimes workflow changes within a clinic. And so that was one big thing that I had as a learner. Next, as a bystander, as I moved into my first transplant pharmacist job after my PGY2, I made sure I attended all of our QAPI meetings regularly, really wanted to listen in, understand, and kind of set the stage for how that I could be involved with it. And then that really led to some of my first participation, which many of you identify with. In how I started was first working on updating our guidelines. So we had, in this time period, we were starting more dual organ, so working on dual organ guidelines, but also updating and providing data to support changes, for example, for valganciclovir dosing post-liver transplant. My really big kind of break, and what made me really want to move into this QAPI leadership, was the first time I got to be a project leader. So I was very fortunate in our hospital quality department does some 90-day like supported pitches in order to move projects forward really quickly. And one of the things that we identified was we had a number of patients who were readmitted post-transplant with hyperglycemia because we were really poorly managing their increased blood sugar after transplant. And this allowed me to become the project lead and lead a quality initiative with the intention of changing practice within 90 days. And so that's when we implemented a pharmacist-driven hyperglycemia management in the ambulatory care setting. It was actually really our biggest dip into ambulatory care at that time. And that was really exciting because I had support from the entire transplant team, plus actually some quality leadership on the hospital side that then moved into me being able to work with my PGY2 that year, move guidelines forward, et cetera. So that was really exciting. And that's really what made me kind of get the bug that this is actually maybe how I wanted my career to change. I then became kind of a participant again. So I took a lateral jump, moving from a transplant pharmacist into a senior transplant data administrator position, meaning that I was a participant in QAPI, but super important, especially from the data perspective. So I was involved with doing things like updating our EMR dashboards and reporting out tie-dye form completion, which we'll talk in some other areas today. And so kind of went back to that participant role with really the goal of moving into the leadership in the role that I'm in now, and became the manager of quality, compliance, and outreach, which part of that encompasses our transplant QAPI. As the manager in QAPI, got to take over all of our transplant QAPI and got to actually create some change. So I was able to change our QAPI format due to kind of inadequate or kind of more structure required, was able to really increase transparency with data and team participation. I think the advantage for me as a pharmacist is I see the multidisciplinary team members and I can make sure that how they're involved in QAPI. And that's been a really big change, I think, and a big plus for that. So really that's kind of my transition into QAPI leadership. And each of those really phases that Tiffany highlighted has been really critical to my growth and how I came into this step. So I'm going to pass it off to Demetra to have her tell us about how she got into this, into her role.
All right, thank you, Liz. And actually, I'm going to share some parallels as I was listening to your story. I was reflecting on my own story, having a lot of similarities. So I started in transplant as a pharmacy student, and ended up, really enjoying my my work, and started to participate and think about doing a residency in organ transplantation. Ended up pursuing that, and during my residency, we actually had a CMS survey. So I had sort of firsthand bystander experience right out of the gate there on the training process with being part of an actual transplant survey. I then really enjoyed uh, systems fixes, and started to do extensive data collection about the patient population that we were treating, and ended up with a pretty large database of all of our patients that we ended up using as a transplant center for various protocol reviews, similar to what you shared, and then also for cost savings initiatives. And actually, my most sort of longstanding partnership in my physician collaborators was actually because I was trying to save the organization money with induction regimens, and this data set that then further got expanded with this project started to include all of our outcomes, various lab values. You may imagine induction is used. We need to collect everything when it comes to that type of a project. So that data set had grown. We started to ask a lot of questions from that data set, and it further grew as each question was brought forward, and then we were answering protocol changes, process changes, whatever it was coming up at the time. I was actually subsequently asked to participate in developing and sort of revamping our quality infrastructure at the organization when I'm going to call it an internal opportunity to review and improve our outcomes and really just develop an infrastructure. So I was asked to help organize that for one of our single organ transplant programs, and really involvement through, this data set is really core to how I ended up here, quite frankly. Enhancing this, and started in the one organ. One piece of advice that I had gotten is because there was a lot of noise in my space, is put your nose to the ground, do good work, and things will align. And sure enough, that's essentially what I did. After a period of time, we got organized, put everything, had a solid foundation in one of the programs. And then I was asked to take on the oversight of the data registry. So of course, collecting information out of the EMR and transcribing it into the UNOS tie-dye third-party registry, essentially, was a major task. Had an opportunity to I'm going a little bit back and forth, but optimize our data submission processes through adoption of our organization with Epic, and really serving as the lead for the organization for transplant in implementation of our Phoenix module, which is sort of the Epic's subspace for transplant patient care and organizing information. After that, there was an additional opportunity to become involved in compliance and regulatory and policy reviews and updates and oversight. So I was involved in that, and at that point we had also expanded. I was also overseeing the activities across all of our transplant programs across. We have 2 campuses at my organization, and so we expanded the efforts and built out an even larger infrastructure. All while, participating in various survey activities that may have come up, or, whatever organizational needs there were, including responding and reporting adverse events, and reporting adverse events and then responding to any inquiries that we may have gotten related to them. And then more recently, I've since expanded in the last year and a half or so into bone marrow transplant. So there's a lot of parallels that I have also come to realize between transplant and other disciplines. And so taking some of the principles and foundational framework that I had worked to put in place for organ transplant as that slow process of growth was ongoing. It's not a literal copy paste, but there's a lot of parallels and then a lot of nuances that need to be handled customly for each of the subpopulation, but ended up doing that. And then more recently now, including pediatrics as well. So it's been it's actually what I shared with you in just a few minutes is a story that has been about 10 years, actually. I was reflecting on that as I was preparing for this. I didn't realize that I had been doing quality work for that long. But it's been a really fun ride. I've definitely always reflected on my pharmacy foundation as I approach each of these, stages that I shared with you all. And I think it's a really great opportunity for us to expand the profession, and happy to be part of it, and also, a great opportunity to share with you all as well. Tiffany, I'll turn it to you. You're on mute, Tiffany.
Thank you. That would have not been fun. So I also have parallels, but I think I'm going to say my story's different. As a pharmacist, I love patients. I love transplant. That's what I wanted to do. I want to move the field forward. I like research. I like figuring things out. I like studying. If we try something new, does it work? How do we do it differently? I got my master's in clinical research my first couple years after residency. My job was actually funded, and my position was funded by the College of Medicine, the Division of Hepatology and Surgery. So they were 50-50 supporting my funds for my job. And I was part of time, about 0.5% of the time, working on clinical research, industry-sponsored studies, and things like that. Well, that's all good, but after a few years, when things start to shift and your funding and what you're doing changes, you have to find other ways to really support your salary and support your position. I never knew that QAPI and being involved in QAPI would be something that would help support or fund my position. But I did a lot of QAPI, right? A lot of the things, as you just heard Liz and Demetra talk about, are projects and things you're doing. You may not realize it is QAPI, or working on, assessing and evaluating how well your programs are doing and trying to improve it and get better. But I was doing, and I was, working on projects, leading projects. But it wasn't until, 1 month or one day that I got an invite to meet with my transplant administrative director. So I'm in the College of Medicine, and they're employed, he is on the hospital side. And he brings me to his office and he starts telling me he needs somebody to lead QAPI and they've had a change and all this. And I'm like, I don't know what you're talking about. So kind of that passive, not even really bystander. I didn't really know. I didn't know a lot about the regulations. And he continued to give me examples of things that I was doing that was doing this and why he thought I would serve the role. So I kind of just like, okay, whatever, next month. So this happened for multiple months. And then finally, when I no longer had the same funding and I had to find a way to fund my position, is when I was like, oh, okay, let's meet. What were you talking about? And then from there, I really kind of self-taught myself about regulations, how you would implement it. What was really intriguing to me is the platform of the program, the way that UC had it before, really wasn't that effective. So we really needed to kind of revamp and change it. So that was what was, intriguing to me. I didn't have to just assume what was already there. I actually got to take the regulations, take what my institution, had for their quality program, and kind of rework it for transplant and do that. So I was like, all right, I kind of felt not forced, but I had to, find a way to fund my job. And then I was able to really create it and build it how I thought best. And then over the years, kind of modify it. As Demetra said, putting this talk together, you think about how long you've been doing it. I've been doing it about 12 years, maybe 13 years. I rely on Liz and Demetra and some of my other colleagues for assistance along the way. And currently, as I said, I'm still directing the program. So I oversee our kidney, pancreas, liver, heart, as well as living donor programs. I also have been able to have a pharmacist be the lead for each of the programs. So I still work clinically in the liver program, so I'm the lead on that program. But for my kidney QAPI program as well as my heart, I have a pharmacist as the lead, which is pretty exciting. And as the other said, I really like what I do. I like being able to kind of create and help direct and really get our practice changes moving forward, learning from things that we have that go right, go wrong, and how to make it better. So a little bit different of a story. It was funding based. It was kind of presented to me and I didn't know what it was. So I kind of ignored it until I couldn't ignore it anymore. And now here I am. So hopefully us sharing a little bit about this just kind of helps you all understand that I think the path and how you get to where you're going can be different, right? Everybody has a different experience. We talked about the pharmacist role and the levels being different. And I think we've, kind of highlighted that. Now we want to shift and really kind of spend the rest of the time talking on strategies for pharmacists to get involved. So I'm going to turn this to Liz to take us through this part.
Yeah. Thank you both for sharing your stories. I think it's cool to hear, right? It's just the little things that trigger us that make us think, oh man, maybe I like this part of it. It's really exciting. So I think it's really nice to hear both of your stories. The first thing about how can you all get involved in QAPI, and maybe there's some ways that you're involved that you actually don't know that you are. So I'm going to work us through this, but I'm going to have Tiffany and Demetra chime in too to give some examples that they may have in their areas where they feel that pharmacists are involved with QAPI in these different steps. So the first one I want to talk about, and when we were putting this together, we came up with the word unconscious contributions. So there are so many things that each of you are doing that you don't even realize that it's this contribution to QAPI in a small way, because maybe it's part of your workflow process. But it's part of your workflow process because it's required for submission of a tie-dye form. It's required for appropriate documentation when we have CMS or Joint Commission or UNOS come in to survey our program. Or it's unconscious contributions because you are working with your team in a way that allows for us to be able to contribute importantly to the team that meets our regulations. So the one example that I'm going to give is the documentation, for example, of Hep B vaccine status. It is a UNOS regulation that we document patients if they've been fully vaccinated or not fully vaccinated for a vaccine, that we've educated the patient on it and then offered vaccination. And that is something that is just built now into our pharmacist workflow, but that is critically important to that tie-dye documentation. And it is even something actually that comes on quite a few UNOS surveys that is maybe not done completely. So I think that that's a great example for unconscious contributions. Demetra or Tiffany, any examples you want to add here?
Sure, I can share one related to pharmacist documentation. So when patients are admitted to the hospital, and sorry, let me start a little further back, actually, a little earlier in the process, when patients are undergoing evaluation, and then we have a multidisciplinary care committee selection conference, or there's a variety of names that these meetings are called in different organizations, but the pharmacist being part of that conversation and that meeting venue, and also hopefully documenting across the institutions around what their thoughts are. Are there any contraindications to transplant? Are there any med changes that need to be taken into consideration? Are there any concerns? Or is the patient clear? So that, just that documentation process, that participation in the meeting, and then that continues when a patient gets admitted for transplant, where induction regimens might be chosen alongside with the pharmacist prior to transplant. I know there are some organizations across the country that the pharmacist participates in those choices. Documenting that information along the lines of Hep B also goes to the data registry submission process, and then of course documenting our education and activities, also part of regulations. And honestly, even beyond the fact that it's part of regulation, it's just going back to the beginning, making sure that the care that we're providing to patients is safe is really at the core.
And I'll just add too, again, that's unconscious, right? We're talking a lot about the documentation piece. So in transplant, right, our donors, we have for deceased donors, we have specific, characteristics of the donor. So we think about donor cultures or donor infectious risks or different positive serologies. So a lot of what we do, perhaps unconsciously as pharmacists, is you include some of this specific, drug therapies that your recipient may be on, whether it's short-term or long-term, based on that donor situation. So you'll have it in your note, but from a quality perspective or a regulatory or safety perspective, I may utilize some of that information as, okay, we knew the donor had this positive result, or we knew the donor was at risk for this. And then we would want to say, from a safety perspective, how do we minimize this risk to our recipient? And the team did X, Y, or Z. And that's often in, what the pharmacist is doing. So that's just another example. Again, I know we're all focused on the documentation piece, but often that's where unconsciously you don't know you're doing it, but your team's asking you to include, or your pharmacy team to include certain things in order to utilize that to fulfill some other goals and objectives.
Thank you both. I think so. Then the next step is learning and understanding transplant QAPI. So Tiffany actually highlighted her own kind of self-guided understanding of QAPI and regulations. I think I can highlight like myself doing that too. But one thing I do want to highlight is that many of you are trainees. So many of you identified as a learner in this system. And this is an opportunity for which you get to understand the QAPI, transplant QAPI regulations. For residency training, competency area R2 is advancing practice and improving patient care. That is literally the definition of QAPI. And really many of these sub-competencies are really related to the QAPI process within transplant. So I think it's really important for you to understand transplant QAPI, both the regulations, UNOS and CMS and OPTN regulations, but also understanding what does QAPI mean at your hospital? What is the larger kind of reporting structure within QAPI? What is your divided by organs? Do all of your organs report through one QAPI structure? Really understanding that as well, especially as you're a learner. And then really understanding too what is that interaction too between your pharmacy department that you might be employed by and also the transplant department, and what is that relationship to it? So I think as a learner, really, and even as not a learner, even as a participant, if this is not something that you feel really comfortable with, being able to use all of those different pieces, not just the regulations, which we've talked a little bit about here, but also what that means for your hospital. As a pharmacist leading QAPI, one thing that we've done within our PGY2, for example, is I offer a 2-week rotation in QAPI. I try to align it up with a QAPI meeting and the preparation for that meeting as a way to really just understand what that looks like. And so encourage many of you to see what those options might look like. Tiffany or Demetra, anything you want to add to understanding QAPI?
Yes, I echo that. We talk about learning and understanding about the regulations, also understanding the regulations, but putting them into practice to be the expert on your team, right? We want to be, knowledge is powerful. We want to know and be the expert on the team in terms of pharmacotherapy, but you could also be the expert on the team in terms of regulation. So many times it's like, oh, if they're listed status 1A for livers, what does that mean? Or what's the criteria for this? You don't have to memorize it, know where it is in the regulations. You can just pull up the policy and see, and you can offer that information to the team. In terms of training and residents, we also have I've started a longitudinal QAPI rotation. So for our PGY2, basically it's 2 times a month. It's longitudinal across the whole year. 1 month, or one of the times, it's a topic conversation, and it's kind of broken down over the 10-month period. So we've reviewed so far the regulations, or first kind of what's QAPI, what does it mean, what does it look like, where did it, what is QAPI not in healthcare versus QAPI in healthcare. Then we looked at the regulations. We looked at our specific transplant regulations. So for here at UC, Next, we're going to go into the hospital QAPI program. What does it look like? And kind of talk about how transplant and the hospital work together. And then starting in January, we're really going to break it down through QA and PI. So quality assessment, what metrics and measures are we monitoring to assess how well our programs are doing? What benchmarks do we compare them to? And then performance improvement, where have we, tailored and focused our efforts and why? So that's our one time a month topic discussions. And then the second meeting a month is she attends our QAPI leadership. So I run this meeting. It's my leads at all the different organs. It's our administrators, and we review, just the different things we do on a monthly basis. So kind of exposure to that. So I think it's going great. I'm very excited to empower next generation to really understand and know this and be able to participate and ask the right questions. So this is our first year doing it, but hopefully it will continue. Demetra, anything else?
No, nothing more to add, just to echo everything you guys said. And that in my organization, we have like an elective for the residency for training. But you guys said it perfectly. Thank you.
Cool. Next one strategy we have here is participate, get involved, and volunteer. And I think that this is the way you step from that bystander into that participant, really being able to offer up your time or offer up your ideas. So really understand who to give your ideas to, offer to help with certain things. So we've highlighted things like protocol reviews, but also highlighting outcomes, sharing events, safety event review with your team. A lot of institutions, right, have a formal, for example, safety reporting system of which medication safety events are reported. And so that is a nice way for a pharmacist to be able to include pharmacist or medication related safety events that get reported through those systems. Also expand and share with larger circles. I think this is a great opportunity for you to hear from the three of us, different ideas to way to get involved, but talk with each other. And if you see opportunities to improve workflows or outcomes, bring those forward. I think one of the things that like really also made me want to make that jump from pharmacist into QAPI leadership, because I remember being on a workflow committee for how we were going to move our pre-liver patients through the system. And I was like, I have so much more to add besides just the pharmacist component. And that was what really made me want to move through. And so you all may have kind of things that you recognize. And to loop this though, then to making your work count, I think making sure you're sharing with transplant administration, pharmacy administration, your projects. And so one example that I'll provide here between participate, get involved, volunteering, and making your work count was, for example, we had recently a kind of a wave of increased amount of CMV after prophylaxis ended. And so that was a great opportunity for the pharmacist to step forward and say, hey, maybe we looked at our CMV protocol few years ago, but maybe something's different now. And being able to really step forward and say, okay, this is our opportunity to look at this. Maybe we need to make a change. And so that was a great example where now we're going to be able to, we're changing our post-transplant CMV prophylaxis protocol in our high-risk patients. And that's really because of changes in immunosuppression over time, which we didn't really take into account when we made those changes. So you likely see these things all the time. And so making sure you bring those forward. Tiffany or Demetra, any examples you want to add to either of these topics?
Yeah, I mean, I think one sort of thought that comes to mind around this is fill the void. There's plenty of work to be done, as we all are certainly aware. And I think when you see an opportunity, again, in the spirit of maybe not directly impacting a patient's care, but indirectly impacting a patient's care. And when there's systems improvements, looking for those opportunities and thinking about what are those elements that frustrate you? What are those elements that you think to yourself and reflect, well, this doesn't make sense. Couldn't we do XYZ in a more streamlined fashion. Those are all real opportunities to actually not only enhance your practice and make your practice more streamlined and efficient and sort of a better positive environment, but also to help everybody around you. And again, most importantly, having the patient in mind. So I think thinking outside, looking for things, thinking outside the box for solutions, and then filling the void and getting involved.
And
Nobody,
just
it's unlikely that somebody will tell you, please don't
Yeah.
fix
Yeah.
And my last comment, just to add to that, is really the strategy is to be flexible, right? You need to be flexible. It's not always your idea, your project. And sometimes to get involved, you can't start with what you want to do, right? You need to be flexible in the sense of understand what your institution goals are, right? What are they trying to meet? I gave the example before about 30-day hospital readmissions. Perhaps it's because of one thing, cost, or one thing different. Work with them, do that project, and then hopefully then the next time you can say, oh, I think about this, or maybe we could do it this way. But be flexible to get to the table, and then you can really share your input, and then they'll see your value and then ask you back at the table.
Yeah, love that. I think kind of as to transition that, also then standardizing your involvement. And so some examples of ways to standardize your role or involvement. So like once you bring an idea to a table, maybe then you can be a regular report out, whether that's reporting out regularly, like Demetra highlighted, a data set, right, that you're utilizing to follow certain metrics, or if it's regularly reporting out patient safety events, or it's regularly reporting out whatever kind of, you have a standard for when you're going to review protocols or guidelines, for example. I think being able to then standardize your role and involvement as your participant is really important actually for that kind of next step for your QAPI involvement, right? Not just a one-off, but more frequently. And realizing that, there's a lot of data out there that can be used for future research projects and sharing personal experiences. So annual reports, STAR files. I think the ACCP AST collaboration for TRAIN for the research is really going to be important for people to understand how to utilize some of the data that's available out there. And so making sure you're utilizing those resources. But also, I think I love Tiffany's example of where there's a pharmacist lead on each organ committee. And that's something that I think is really important too, and consider standardizing the pharmacist role across all organs. Like maybe it is a different QAPI committee, but trying to standardize that role too could be really valuable to all members of the pharmacist team. Tiffany or Demetra, any ideas or additional points for kind of standardizing that role or involvement?
One thing is just in terms of standardization, your programs, again, learning about your QAPI program, your QAPI structure, the requirements and regulations really talk about these metrics or measures, or the way that quality assurance, the way you take a look at your program and how it's doing. And they want you to do it per organ. They want you to do it for the pre-phase, the peri-transplant phase, the post-phase. You have different measures and metrics. It could be length of stay. It could be, rate of DGF at post-kidney transplant, or whatever it may be. This is a great opportunity for pharmacists to get involved. You can get involved on the pre-side, the inpatient or peri side, and then the post side, and really kind of standardize which measures or metrics that the pharmacist can contribute to. Would be another opportunity for pharmacists to get involved and really participate in that structure or QAPI program.
Yeah, that's a good. No, yeah, I think that's a good point. Every program is required to have a QAPI plan, which summarizes all those metrics that Tiffany just mentioned, and learning what that is and where maybe make one of those line items at least or more a pharmacy scoped item would certainly again be very welcome. I think also standardization is important just because it's so foundational. It really sets the stage for how you're going to do everything at base, and then you can iterate and improve and grow from that standard foundation that is standardized. The other thing is that there's a lot of interoperability between quality and research. At the core of both is data. Certainly really important to make sure that you're following best practices for approvals and channels for IRB approvals and approval channels to use data that might be for quality and for research as well. But I think it's also important to think about what is possible to share broadly, because there's things that you might be solving for within your organization that make a difference, but there are others across the world, quite frankly, that could also benefit from seeing the work that you're doing. So, it kind of all of these kind of work together. It also counts into make your work count, like make it broad, make it big, and share all of the good work that you're doing as high and wide as you can.
And that really launches the last point, right? Use QAPI as a mechanism for research. One of the big things, like we always have our PGY2 present their research project to QAPI before then they present it at ATC, for example, and making it count. As Demetra highlighted, as big as possible. You never know how much this is going to impact other people. And so using it really as a mechanism for research and to answer those questions.
And just to add, not only just research, but also collaboration. As we're sitting here, I'm thinking of many times in our program, we actually have QAPI every week on our kidney and liver teams as part of our selection meeting. So we have an 1.5-hour meeting. We have selection and inpatient discussion for an hour. And then the last 30 minutes is QAPI. We talk about protocols. We talk about case reviews, different things like that. But we often have, different providers, different members of the team talk about something they're working on. It's a great opportunity to volunteer. We started a cardiovascular type screening project. One of the hepatologists was talking about it, and the inpatient pharmacist volunteered they could do the screening. So again, it's a way to collaborate, and then that grows, the research. So I think those are all great mechanisms. Anything else to add here, Demetra, before we move forward? Okay, perfect. So again, we went through just some examples. We felt that this would be helpful really to get you thinking of some strategies to get involved. Really the main thing and the resource we want you to think about over and over again is what is happening at your specific institution and your program. The three of us talking to you today could each pull up our QAPI plan. Sure, there could be similarities, but most likely they're different. They're different because they have to fit within your institution and your pharmacy or your transplant programs. So learn about it, understand it, know who the QAPI manager, the QAPI director or leader is, and really try to talk with them to see some of the ways you could potentially get involved. Just quickly, important resources are the OPTN policies for QAPI, which are under the management and membership policies. In terms of CMS, the final rule and interpretive guidelines talk about QAPI. There's some community. There's a crosswalk, which kind of compares CMS and OPTN. It's through the Organ Donation Alliance, a link. You just have to log in and create an account and you can access it. There's a quality group. And then, of course, the SRTR and UNOS, which I assume and hope you are familiar with these websites, but you can look at it in terms of some data and ways to navigate and get information for projects. So we briefly went through, we think, some great strategies to help you really get involved or to change your level of involvement as in QAPI. And at this point, we really want to open it up. We have 10 minutes left for questions and discussion. I don't think that I see anything in the chat, but if you have anything, please put it in the chat or I think you can unmute and ask a question. I mean, we really want this to be for you guys listening. What did we not talk about and how can we answer? Anybody have anything?
I'll go ahead and throw a first question out for the group. Beyond your entering into your roles for the three of you, what was your biggest eye-opening experience when you went into a QAPI role, transitioning from a pharmacist, that type of thing? Like what surprised you the most, and maybe what's your biggest barrier that you see versus being a pharmacist at the bedside and trying to change things?
For me, I think it's just navigating within my health system. Transplant's not a service line here in Cincinnati. We have our providers in the college. We have a hospital. We have our administrators on the hospital side. So to try to do a QAPI program and bring all these people together, it can be done, but I think that was the most eye-opening and challenging way to really navigate it and understand how to do it. There isn't, there's not a rule book or a guidebook on how to do it. And I continuously have to change it. But it's not just, it's not as simple as it would be if we were all in the same place or service line and could just, kind of all flow in the same manner. For me, at least.
I can share. For me, I actually struggled with my entry into this because it was something that I was sort of asked to participate and build, and I was of course excited to build um, something, right? That the entity of the quality program. But also it was very scary because it was a moment in time within the organization where there was regulatory risk. And I really didn't know what I was getting myself into. And I also was in parallel struggling with an identity crisis but I'm a pharmacist, right? And so I want to make sure that I am so focused on the pharmacy stuff elements. I think, and Tiffany, we have a service line at my organization, and it's just as complicated when you have a service line. So don't feel bad. The second half would be navigating all the complexities. I think the other thing is that, and this may sound like I had really intense blinders on, but one of the things that was eye-opening to me is that pharmacists are different, but we do generally think alike. And so when I would say something in the pharmacy department, people just got it in what I was saying. And in the outside world, the broader world, I wasn't able to just use that same approach. I had to enhance negotiation tactics, change negotiation tactics, change the way I was presenting what I was saying and how I was saying it. And so that was really, it sounds very naive when I think back to it, but that was actually one of my biggest challenges is the navigation of, I'll just come out and say it, is politics, and really like sort of that broader world. Not that doesn't exist within a department of pharmacy, but it's a little bit more streamlined and standardized in that department. And so that was something that was really eye-opening and a bit scary, but I will confidently tell you it is manageable, it is doable, and it's how you manage it and how you react to the circumstances, and then just mobilize and organize people in a different fashion. So a little bit of the fear, but also it's success is possible, and achieving this is doable. So I'm still encouraging people to in the audience here to think about this as a field.
Yeah, and I think I would add to that like a couple of things. So when I was negotiating my role and what that would look like for me, it was important to keep a clinical component. Mine looks different from Tiffany, which looks different from Timitra. So I cover as a clinical pharmacist twice a month, typically on an inpatient service, and I'm an abdominal transplant pharmacist primarily. And so I think so that was what was important to me, Nicole, because I still wanted to have, I think what makes any pharmacist really good for QAPI is that you have the clinical understanding of how that team functions, right? We have people who are trained as quality and safety specialists, but don't have the piece of a transplant clinician. And it does bring an entirely different perspective. When I have someone say, oh, we should just change this part of rounds. And I'm like, no, we can't change this part of rounds because of like this, that, and the other, right? I think that's like really valuable, and it brings that pharmacist like piece over. I think one of my challenges to kind of snowball a little bit off Dimitra's is in the pharmacy department, very regimented in terms of how do we make changes, right? A lot of thought in terms of workflow changes, a lot of thought in terms of like the different pieces and how they fit together. And sometimes I found working with other providers, it was like, all right, well, you know what you need to do, just go ahead and do it. And I'm like, no, we have to think about these things out. And so I think that was my biggest challenge is Still trying to actually work with the speed of maybe how the department wanted to move things, but still including the pharmacist kind of mentality of, okay, making sure I have all the pieces together. I think that was a challenge for me, kind of marrying those two pieces.
Thank you, guys. We actually have one more question. What are some of the other pharmacy-specific metrics that you recommend transplant pharmacists add to their QAPI trackers?
One that comes to mind is in addition to just protocol tracking, is protocol adherence, and maybe and details around why it's not adhered to. So that's something that we do at my organization that has been very helpful, because it's of course there's order sets and structure, but sometimes we digress from those core standards because of different patient issues. And so could that represent an opportunity so could a deviation represent an opportunity that's a one-off, or is it really a systematic thing that could be optimized for most patients? DVTs and oh, sorry, Tiffany, I was going to give one more. DVTs also comes to mind as an opportunity that is not directly thinking of a pharmacist, but that we can certainly have a role in. Those are just two examples that come to mind.
I was just going to make a general statement. Sorry about that. I was just going to say, add trackers of your interventions that are meaningful to your program or your institution. So if it's DVT prophylaxis, if it's that you talked about, Liz gave the example of CMV and an increase of incidence. We added monitoring post-prophylaxis in our high-risk patients. So we monitor every 2 weeks times 3. So we're doing that. Add that, track it, try to get those measures and the things that you're doing to your pharmacy, or sorry, to your quality dashboard or your quality metrics. Like, what is important to the institution of the things you're doing. So I think interventions, things you're doing that have an effect on an outcome, and things that you want to do, like if it's protocol or protocol adherence and you're completing that, but try to take it a step further in terms of something that impacts an outcome, and especially if it's an outcome that your leadership cares about.
Yeah, I was just going to add to what Tiffany kind of highlighted it, but just to define it, I would suggest a process metric and an outcome metric. And I think really important, right, that you contribute both of those things.
And if you can attach a cost, right, that is always super helpful for people. Just throwing that in there.
All right. Thank you, Liz, Tiffany, and Demetra for speaking today, for your insights and all of your experiences in your transplant QAPI roles. Just as a reminder, the webinar is approved for 1 hour of ACPE credit. The participants will receive an email tomorrow with the link to obtain the CE credit. Okay. Thank you, everybody, for joining today. Really appreciate it, and have a good holiday season.
Thank
Thank
you.
you.
Thanks.